Okay, so now let's take a look at a pathology down here on the bottom left of your paper. So this is the right lung, so bottom right lung, okay? Over here in the normal gas exchange process, the smooth muscle is relaxed, okay? In this case, however, let's make the smooth muscle constricted. Very, very tight, okay? We call this bronchoconstriction. And that is because the smooth muscle has constricted, and is now impeding airflow through this bronchiole here, okay? So here we have, we'll keep O2 over here in the corner. These colored pencils keep breaking on me, okay? So the O2 that you inhale is going to end up here. Now the problem is it should be able to get to the alveoli easily, but it can't because we have bronchoconstriction. So I'm going to put like a wiggly line here, okay? So that means that we're not going to have a huge concentration gradient of oxygen in the alveoli. It's still going to be larger than the amount of, the concentration of oxygen is still going to be higher in the alveoli than in the capillary. But the problem is that the concentration gradient is not very, very great. So this oxygen will diffuse, but not at a higher rate, okay? So here's the oxygen, and now we're going to carry that to the rest of the body through the capillary, okay? But the problem is that we've got a decrease in the diffusion of oxygen, okay? And we're still doing cellular respiration because we're still getting some oxygen to the end tissues. So we're going to get some CO2 coming from the body. Okay, so we've got CO2, we've got a high concentration of CO2, 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 and it's not going to have any problem whatsoever diffusing from the alveolus, from the capillary into the alveolus initially, because we've got a high concentration, low concentration, we've got a very steep concentration gradient for now, so the CO2 is going to diffuse into the alveolus. And then when you exhale, we're going to get rid of the CO2. Oh, but the problem is that we're having trouble getting past this constriction right here. So what's going to happen is it's going to slow down the egress of CO2 from the alveolus. So CO2 is going to build up here, which means you're eventually going to have a concentration gradient that's going to be very, very, very slight. Okay? So that's going to slow the amount of CO2 we're getting out of the bloodstream, which is going to change the blood chemistry. Okay? We call what is happening here due to the bronchoconstriction, we call that bronchoconstriction. So asthma is a prime example of bronchoconstriction. Okay, so what do we do for this bronchoconstriction? Well, the problem is that the smooth muscle is too constricted, so it's strangling the bronchioles. So signs and symptoms of bronchoconstriction could be chest pain or chest discomfort, chest tightness, trouble breathing. Typically, we're going to hear wheezing when you listen to lung sounds. You might, if the wheezing is going to be everywhere in the lung fields, not just in the bases, not just in the apices, not just right lung, not just left lung, in an asthma attack. Now, if you have like bronchitis or a pneumonia, you're going to get localized wheezing, okay? If the bronchoconstriction is ramped up a lot, you're going to hear diminished lung sounds. If it's really ramped up, if someone's having a severe asthma attack, you might hear no lung sounds, okay? That is a true emergency. Some other signs and symptoms, you're going to have a low pulse ox, and you're going to have a high amount of CO2 in the bloodstream. The terminology we use for that is hypercarbic. Okay, and the treatment for that is, first we're going to give oxygen, and then we're going to give beta-2 agonistic meds. Remember, we have one heart, beta-1, two lungs, beta-2. So we're going to target beta-2 receptors in the smooth muscles surrounding the bronchioles. And when you agonize them, when you turn on those receptors, it's going to cause the smooth muscle to relax. In addition, what we can do is we can give steroids, which will reduce inflammation. And in severe cases of bronchoconstriction, we're going to give epinephrine, otherwise known as adrenaline, like an EpiPen. This is the reason we give EpiPens in allergic reactions. It has three very, very powerful effects. Okay, it has positive alpha-1 effects, so it's going to vasoconstrict the patient and jack up systemic vascular resistance. Do we care about that in bronchoconstriction? No, not really. We do care about that in allergic reactions, though. It's also going to affect beta-1. It's going to jack up your heart rate. Do we necessarily want that? No, not really. But what we really, really do want is a positive beta-2 effect. It's going to bronchodilate. And it's a very, very powerful bronchodilator. Okay? So to summarize, the treatment for severe bronchoconstriction is give oxygen, give beta-2 agonistic meds, give steroids, and give epinephrine if it's truly, truly life-threatening.